Hello, thank you for joining us in The Loop. If this is your first time with us, this is the podcast where we invite leading figures to reflect on the major challenges in health and care with the two of us. That is, me, Niall Dixon, a former broadcaster, Chief Executive of the NHS Confederation, General Medical Council and the King's Fund.
And me, Roy Lilly, I'm a former NHS Trust Chairman and they call me a commentator, but I can't spell it.
Our guest this time is Dame Jennifer Dixon, no relation incidentally, although Jennifer did work with me at the King's Fund as our policy director in the 2000s. Jennifer went on to lead the Nuffield Trust before taking over the wealthiest of the health think tanks, the Health Foundation. She initially trained in paediatric medicine before moving into public health. At the King's Fund, she pioneered work on the management of long-term conditions, predicting the huge growth in chronic disease and its impact on the NHS and indeed healthcare systems around the world. She also led research into the role of the market in the NHS, regulation and NHS funding. At the Nuffield Trust, she re-established the organisation as a force in health policy before moving on to her present role as Chief Executive of the Health Foundation. There, she's commissioned numerous national inquiries, including into the health of young people, the impacts of COVID, and into the health of people at work. With the Institute for Fiscal Studies, she published an analysis of NHS and social care funding, which I commissioned from the NHS Confederation in 2018, leading to a decision by the government to invest an additional 20 billion in the NHS. Jennifer has also co-founded a fellowship programme for European health leaders, and she played a role in establishing the Health Improvement Studies Institute in 2016, based at Cambridge University. Now, we're speaking to Jennifer at this time against the background of a newish government which seems to be flirting with market mechanisms which at one time Jennifer advocated. We have a massive upheaval with another reorganisation, which we've touched on with previous guests, but it will also be good to get her take on this and, of course, the new 10-year plan Fit for the Future. What does she make of this? A blueprint, arguably with the right ambitions, but perhaps without the funding, the social care reform, or a timetable to realise its ambitions. Roy, in some ways we do appear to be going back in time to the reforms of the 2000s and the return of key figures such as Alan Milburn, Ara Darzi and Paul Corrigan, who dominated the new Labour years. And in some respects, Jennifer was part of all that. And whatever they achieved, I guess the question is, do they have the tools to deliver this time round? What do you think?
It's a really good question, Neil. We've recorded a very interesting session with Ara Darzi because in it, I thought Ara Darzi was quite reflective, really, on the success that had come out of the various reports that he'd done. And if you look back on the Milburn years, the things that he introduced, like the markets and choice and any qualified provider, all of that was gone by 2011. And so my question is really, it didn't work then. Why should it work now? And that's the big question I have for the big brains from the think tanks.
Jennifer, welcome to In the Loop. It's fair to say that we're at a bit of a junction point for the NHS, with at least the promise that we'll move from years of austerity to some kind of better place. But we're still seeing funding in real terms well below historic average. We're entering one of the biggest reorganisations in the history of countless reorganisations in the NHS. So how do you view this point that we're at?
Well, this programme is called In the Loop, but I'm sure you feel the same, that we've been round this loop many, many times. I mean, I think the first thing to start off with is that probably what lots of people say, which is the conditions at the moment are actually the most challenging that I've seen in 41 years since I qualified as a doctor. There's a funding challenge that you mentioned. There's the workforce challenge, as you know, demand and supply pressures, all those things. But also the political environment and texture is quite polarised and toxic. You know, social media and the unforgiving nature of the media cycle is just really making things incredibly difficult and making headway very difficult. So I think it's just a really, really unusual time. The 2.8% real terms growth that we've been given is, as we know, less than we normally are used to. And that's when times are good. So how on earth we can cope on this situation is a tricky one. And I think it's really tricky when you set up the rhetoric of reform or die. Because if you have a very, 168 page of a long-term plan, a 10-year plan rather, You have 2.8% real terms growth. So you have this huge expectation, not much money, lots of challenges, and the NHS perhaps can't respond to all of those. Is there really death on the horizon? Why are you setting it up quite like that? Because further down the track, there's political problems. So I think it's just an unusual time. And I think, we're going to have to cool the rhetoric, change the narrative, get a little more real, and try and make modest progress on a few must-dos, I think, is as much as we can do with a few bits of groundwork and some technology over the following few years after that. But I think reform or die is not a very helpful framing to this period now.
What do you make of abolishing NHS England?
Well, I thought it was an unnecessary motivation sapping chainsaw maneuver that was really unwise. I don't think it's unwise to think about how you might merge those two. I don't think it's unwise to think about how you might slim down the staff. But I do think it was unwise to do such a sudden shock and awe announcement that at a stroke seemed quite disrespectful and menacing. And to do it so quickly without people knowing, why sell that capital that you need of all those leaders in those systems? So why sell it so cheaply? So do it, but do it judiciously, do it with a scalpel, not a chainsaw. Don't do it quite with so much relish or performative oomph, and have some respect for the people working in it.
I think that's really interesting. I've had some of the most distressing emails from people whose careers have been thoroughly committed in it, mainly managers that do, highly sort of esoteric NHS-y type management things, which aren't really transferable elsewhere. And, one guy was 48. He said, it looks like I'm going to get the sack. I don't know when. I don't know how it's going to happen. I don't know if I'm going to be made redundant. I don't really know how much I'm going to get. I don't know what the formula is. How can I pay my mortgage? It's just bloody cruel to treat people like that. Do you know how it came about? I mean, the story is it was over one weekend and they came in on a Monday morning and said, we're going to slash the whole lot in half. Is that true?
I don't know if it's true, but I heard the same story. I mean, I think this is interesting because if you think about where this might be coming from, it's coming out of a sort of, we're in combat mode and people aren't doing what they need to do and therefore we're going to make them. There's a sort of menace undertone, I think. I put this to Alan Milburn last Friday in my podcast and he was saying actually that's, he didn't really accept the word menace, of course not, but it's coming from that. And really, if you have a situation that we've got with all these challenges without much money, what you do have is huge human assets in the system that you need to mobilise. So don't sell them off cheaply. So I do think this combat mode, this tribal, it's quite political and it's, sorry to say, quite male, very male. Don't do it. Just think about all the assets you need and be more diplomatic and more sophisticated about it.
The political leadership of this has been brutal. And we've heard this before, actually, from governments of different colour, where they say white coat good, grey suit bad, and it's juvenile and it doesn't remotely deal with the complexity of the system. I wonder if I could just take us to the funding question, Jennifer. I remember I commissioned you and the Institute for Fiscal Studies to do what I think was a really important piece of work on what sort of funding would be needed from, I think it was 2018, onwards for the next 10 or 15 years for health and care. And the figure was around 4% for both, just to keep the thing going. So how can we possibly achieve all this wonderful stuff that the government is saying they're going to do with 2.8%?
Well, it's not going to be possible, that's for a start. I think looking at other health systems, everyone else is facing the same issues. You go to Germany, they've got existential crisis of hospitals and having to close quite a few. The Netherlands, as was lauded by the policy exchange piece, France, everyone is facing the same huge issues, which is how on earth to match the supply demand mismatch going forwards with our economies having circa 1.2% growth in future. So everybody is trying to face this issue, whether it's a social insurance model or a model like ours. Obviously, the big, slightly unrealistic, perhaps, hope is tech. which is why the 10-year plan is pretty techno-ecstatic, but really majors on that. That's going to help, isn't it? Whether it's going to really produce the productivity changes that we need. It's not just tech, it's also if you open up neighbourhood health services to be far more upstream as you want to tackle wider determinants. That's a bit of a leaky bucket if the NHS gets into that, important though it is. And the other leaky bucket is, of course, all the genetics revolution and the personalised care, because you'll get people like me who are healthy but are risk averse, running around with risk algorithms, polygenic risk scores attached to us, getting more and more worried and maybe making more demands on the system. So that's the logic of the 10-year plan. So even if you look at Kaiser Permanente's approach to some of this, it does have limits. So although 20 years ago I was writing paper after paper about rationing, I don't think we need to go quite there on the basket of benefits as we did in the past, but we do need to think about how to protect going forwards the potential for large demand coming from those two areas in particular. So those are two limits that we have to talk about at the moment. We may get into a situation where we really feel that we have to start getting much more money into the system through some other route. I don't think we're there yet, but we may well have to face it if improvement isn't progressed fast enough.
Can I just ask one thing, which is you talked about leaky buckets in relation to wider determinants of health. Can you just expand that?
Sorry, I'll probably be cancelled for saying this, but all I'm trying to say is somebody has to go upstream to help prevent ill health, but the extent to which the NHS can do that, given the funding constraint on it, I think needs to be discussed more fully, because I think if we allow a lot of autonomy with the new ICBs, that some may be very interested in going upstream and spending more NHS funds that way, and possibly at the expense of basic services that need to be in a full and florid form. So much though I am a flag waver for wider determinants and inequalities, I do think we have to think not to compromise on inequalities, but to really think much harder about what are basic NHS services that we really have to cover going forwards in any universal health system.
There's two interesting points there, Jennifer. One is the role of the NHS in what is essentially public health or the public's health. Does the NHS actually have a role in the wider determinants of health? Because, they're housing, they're the environment, they're the jobs that we do. It's how we bring kids up. I'm a big fan of that. But I'm just wondering if really we got to the time when we say, look, we're a fix you up service. Whatever we got to do to stop you getting sick in the first place, that's somebody else's job. And we can't do both unless you give us the money to do both. And the second thing was the IT thing. I don't think, because of the very low standard of the IT that we've got now, I don't see how we connect any of this sophisticated stuff to what we've got. We can mutualize data and we can get some of it talking to others. But how you connect into what is essentially a Calagas system into a real, laser future, I don't see how we do it.
I mean, I think on the wider determinants, I do think the NHS has got to really focus on secondary prevention, not necessarily primary prevention. And it's a bit disappointing we haven't had the major condition strategy. Do you remember that was promised just before the election? So we really need to focus on that, and ICBs, I think, really need to focus on that. In terms of primary prevention, it may make sense in some areas where it's egregious that clearly something is happening to affect health that's creating avoidable demand. But really, a lot of this is the local authorities that really should be in this space. So that's what I think the priority should be. I do think, however, that the NHS has a role as an anchor institution, particularly in places like the North East, where the level of industry is far less than in the South East, and the NHS is a major employer up there. So by an anchor institution, I mean using its asset more carefully to procure local services more, perhaps try and train local people more into that kind of thing. It has a role which would benefit health. But I think the basic point you're making is a good one, which is there are limits to the wider determinants contribution of the NHS. And that's what I was saying, going back to Kaiser Permanente. If you look at what they do in the West Coast, they are very hot on preventing demand, but they make only limited forays into wider population health. And there's a secondary prevention agenda that's quite strong. So we should learn from that. On the IT side, couldn't agree with you more, Roy. I think personally, if you can't do everything everywhere all at once on IT maturity, data maturity, I think this is a time for the NHS to show some hope by giving really good national demonstrations in some places, so that at least where you've got the most data mature sites, the most able IT people, you've got clinicians using this stuff, we can at least show and demonstrate to the rest of the country what might be possible with a bit more investment on maturity. But at the moment, it's quite foggy as to what the future even looks like. And this is a question for the Secretary of State, how far you're prepared in your wish for autonomy, or at least professed wish in autonomy in the system. How far do you say we're going to really think about this and demonstrate the future for tech in some areas, even if they are Cambridge and London, just to show what might be possible?
The how you do this is as important as what it is you want to do. Is more important, really. We all know large organizations can't do more than 3 things at once. And that's even a struggle on top of everything else. So, how do you pick a winner?
And I think on that IT tech side, I would like to see some national demos on some service shifting technologies, productivity enhancing, labour saving technologies, not just the life sciences, treat the clinical condition better technologies, if you see what I mean.
Yeah. You talk to the junior doctors who are going to go on strike, half of them are more worried about the fact it takes 15 minutes to log in the morning. The IT drives them balmy, and that's, one of the things they quite like to get fixed.
So social care has been kicked down the road. So I guess the first question is, do you think the NHS can be solved without both radical funding, which we talked about, and reform of social care? And allied to that social care question, what do you think of this idea of integrated health and care provider organisations?
Yes, so I'm hesitating here because, Neil, I know you're the expert on social care. I think the NHS is always going to struggle unless we have a better solution to social care. That's clear, isn't it? Because if you look at one of the biggest growth industries in the future is going to be death and end of life, looking at the baby boom sort of hump, my generation, that's going to hit the buffers. So we have to sort out social care for sure. So what do I think of integrated health and social care organisations? I don't know. We have had organisations, look at Northern Ireland, they have health and social care integration for quite some time, haven't they? I'm not sure this is a structural issue. I think this is a collaboration issue more than a structural one. So I'd like to see more aspects of care that are collaborative, which includes data, it includes people working together, it includes payment mechanisms that somehow encourage this. Maybe regulation, don't know, rather than a structural, put them all together because we haven't tried that yet kind of response.
I think the problem with social care is best illustrated in the Better Care Fund, where the health service can lob in some money and social services can lob in some money. And we hope that lot of money will help sort out some stuff. And so the answer to the problem here is not being able to work together. And it's not that we don't know how to do it, or it's not that it isn't needed. It's just the fact that social care is skint and it's had its budgets cut in half and it's never recovered from what happened during the world banking crisis. They've never recovered. We've got lots of tiny domiciliary care organisations that need some consolidation in the market, but they can't do it because they're all existing on a shoestring and only making a few quid. None of them make a substantial profit properly. And the answer is pay them to do the job and they'll do the job.
I agree that the money is absolutely crucial, and obviously social care has been starved of funding. I also do believe that there are cultural issues between both the NHS and social care, and that cooperation, which is less easy when there's shortages of money on all sides, but there also is often a failure to understand where the other is at. And you saw that during COVID, where in some areas, and particularly interestingly enough, where a health organisation was running social care, as in Salford, where they treated nursing homes as effectively other wards within their organisation, gave them the support, the PPE and the advice and the expertise in terms of infection control and all the rest of it. Whereas in other places, they just pulled the barriers down and social care was left to struggle, often in desperate circumstances on their own. So I do think there is something about how you cooperate. Trying it structurally may actually do good things. It certainly hasn't worked in Northern Ireland, but there may be other factors which are causing it not to work there.
No, I was going to say these, what are they called? Integrated health organisations that we're going to be piloting. I can't remember whether one of the aspects of that is to pilot a social care bit in them. But if not, that
Yes.
might be the place to try it. Yeah.
But the bottom of all this is money, because they don't have enough money to commission proper services from a disaggregated ragbag of providers. And until there's money in the system, people won't come in and do it. And thank God there are people who do it.
I think that point about culture is interesting, though. I entirely accept the point about the funding. Can I just ask, in terms of culture, all this is only going to be achieved, whatever is achieved, is going to be achieved by the staff. And we've touched a little bit about this. We appear to have angry doctors, nurses disillusioned with government and the NHS and employers. I just wonder, Jennifer, do you think we need a different approach? And I suppose allied to that again, how different will the roles of doctors, nurses and other professionals be in this digital revolution age? Are they also needing to change their attitudes and views, as well as the employer having to do a better job?
I mean, just on that last one for a minute, we do a survey regularly with Ipsos, I think it's with this Ipsos, on attitudes to technology and use of technology, and staff are very positive about it. At least that's how they report it. It's also clear that, as we've seen from other attempts to change roles with the physicians' associates, for example, that the clinicians will also be worried about their possibly being displaced in future or their job changing beyond recognition. So that has to be factored in. But the signs are good on the tech side. I do think the point you raised, Neil, is an obviously important one. But the texture of what's going on in the profession at the moment, particularly the medical profession, is really unusual in that there's this very angry, it's not just doctor's voice either. I kind of wonder about the buying into the collective in future. The obviously the deference to any kind of authority, the wanting to have a life, of course, and not being less prepared to subserviate yourself to the system in the way that I did and my colleagues did. And I'm not sure we've got our hands around the contours of all of that. And this isn't just soft stuff. This is really causing an issue at the moment, not just with the BMA, but throughout. I went to one hospital that shall be unnamed, and the chief medical officer was trying to make some progress on some aspect of care and needed to speak to a lot of the juniors. And half of them just refused to turn on their camera on this Teams call. And they just put barbed comments in the chat in the way that was the most disrespectful. And he was showing me these comments. That was utterly unheard of, that someone would do that. So there's something really quite real that we haven't addressed. There's a lot of things here, but one of the very basic things is, of course, how we treat juniors, require them to go around the country in the way I never did. There's no firm any longer where someone was looking after you and you could learn through tacit knowledge. It's much more transactional, sporadic. You feel, you're not feel looked after. You don't therefore feel trust. You don't feel as if you want to give anything back so much. So Jill Lang came across a lot of it with her report. So I do think there needs to be a special report on this, because the system isn't getting what we got out of the juniors and the juniors aren't as fulfilled. So that really does need to be addressed.
Do you think that applies to the whole profession, indeed to maybe two professions, plural? And is there something also, you touched on the deference question, is there something also about the compact between patients and doctors that has also changed as a result of digital age, lack of deference, I know as much as the doctor does, and the rest of it?
Well, I was looking at, I can't remember what it was. It was a survey recently. I think it was one of the medical graduate surveys, which looked at difference in attitude. This is among doctors, between older doctors and younger doctors, about the amount of discretionary effort they were prepared to put in and so on. It was a very, very marked difference between the old and the young, as you'd expect. A lot more stress in the young. The old were just much happier in their work, much happier to give lots of free time to it, happy to help colleagues than the younger ones were. And the aggression, patience towards authority, that's a long run trend. So I think this has been described for some time, but I think it's just got to be a kind of fever pitch at the moment. And I don't think we can ignore it for any longer and just watch these things sliding away from us. So the question is then what to be done. And I do think some very basic practical things need to be addressed with the young doctors. Maybe in other professions in healthcare, I haven't looked at those particularly, but I'd be surprised if there was that much difference.
I think there are structural things wrong that the doctors and the nurses and everybody really has got an absolute right to rail against. And there was a time when people wanted a job for life, and now people want a job and a life. I mean, that's just the way of the world. We've got to get over it. We've got to move on. And it's interesting, isn't it? Because all professions end up getting de-skilled, get taskified, because it's cheaper. And we can see what's happening. I'm going to get an e-box full of abuse for saying this. We're going to have these associate professionals coming in that are cheaper and quicker to train, supported when we get it all sorted out with decision support, with machine learning and what we call artificial intelligence. They'll be overseen by senior doctors with a lot of experience who are paid a lot of money. And that middle group, it'll go. It's gone in engineering. It's gone in architecture. It's gone in the law. All of the professions end up being de-skilled and taskified. And there is nothing that I can see that will stop it happening in health. And, you can argue that the junior doctors, by their behaviour, are simply hastening government's appetite to make sure it doesn't happen again. They've got two things they could do. They can either pass a law and stop doctors going on strike, or they just don't use those doctors. They use other ununionized bits of staffing and technology, and you can see it happening.
There was a very interesting FT Book of the Year way back 2018, which is about what AI was doing to the professions. One of the things that was very interesting about the medicine is what can be protocolized will be protocolized. A lot of what clinicians do at the moment can be quite easily protocolized, leaving the less protocolized stuff to the physicians, those at the top of their license, of which there will still need to be quite a lot of those. So medicine becomes more of an art because there's just so many things that can't be protocolized. It's really hunch, it's experience. So that could be very more satisfying than the current medicine that people are doing. But you also need quite a significant cadre to replace the very senior people, as you describe. So we just may need fewer of those people, but they may well be more satisfied as they go forwards. And they have this sort of more cookbook medicine, if you like, lifted off them in a way that could help. So it could be a very positive thing if it's embraced. The good news is that wherever I look, there is so much talent in medicine, young,
Yes.
old, everything. It's absolutely eye-wateringly good. What I don't see so much of, and this is where I'll get cancelled again, is I'm not so sure I see enough leadership within the profession embracing all of this. And you just have to look at who's been looking at AI and what they've been saying about it. It's not really very fulsome. There's no Eric Topol equivalent, for example. And I think we just need that now.
So that is a really interesting question about who is making the noise. The BMA have a history of saying no to things. We have asked this of others. If you take all this together, not just the staffing issue, but the technology, the funding, the social care, and all the rest of it, and the high ambition, how optimistic are you that, I don't know, after, say, 5 years, we could be speaking about a radically different service that's clearly on a journey that patients and staff have embraced?
I have no doubt the NHS will find the right path. The question is, can it do it quickly enough? And I think the chainsaw, the sudden disruptions, political or managerial, whatever it is, don't help. I think we need faster evolution rather than rip it up and start again. So I think the issue is there may be more overwhelm. And if there is, I don't suspect there'll be a sudden royal commission to say, should we end the NHS? And I just think things would happen around the edges, not least people leaving the NHS if they don't feel that they can get the care there, a bit as dentistry did. I don't know. I think the next 5 years are going to be the most critical in the NHS's existence, to be honest. And we're going to need all the talent and leadership and stability, of course, and collective strategy about what to do. And unless we engage all those assets, unless we can pull them all together into some unifying pathway, broad pathway, we are going to face a problem in the future. And we have to change our rhetoric completely to say we're going to give it a really good try and engage as many people. And this whole aggressive combat has got to change. And so, sorry, that's a rather foggy answer to your question there, Neil. But I hope that with the talent we've got, we can do it. But we must have stability of purpose.
I'm pretty sure we've got the talent to do it, Jennifer. But it's the leadership, crystal clear leadership. We are, over the next 5 years, we're going to do this, or over the next 3 years, we're going to do that. Keep it simple, keep it achievable, keep it doable, and people will be motivated by it. But at the moment, they've got nothing to motivate them other than worry about where their next job's going to come from and what a rotten life it is to be a doctor. So is that political leadership? Is it NHS leadership?
I do think it has to be all of it, probably led by politicians who can also develop the proper narrative with the public as well on this. But everyone needs to step up.
It isn't the danger that the politicians, this time around especially, they've created this crisis, as it were, and saying it's do or die. But they've also said this plan will transform the NHS in a way that's never been transformed before, and so on. And therefore, the rhetoric runs ahead of delivery. And that's a real problem. Now, to be fair, if you go back to the 2000s, I know Roy is more critical of that period than I am, but they did manage to bring down waiting lists, and they were very clear that they would do that, though there was quite a lot of skepticism at the beginning that they would reduce it down to 18 weeks. That seemed completely impossible. But of course, they had huge amounts of money. So actually, in the end, the rhetoric and the delivery kind of matched one another. Didn't do them any good politically in 2010, I have to say, but it did match a bit of that. And of course, they hit the buffers a bit in 2008 when all the things went wrong on the financial front. But it worries me that on the one hand, they've hyped this up. And as I think you've both reflected in this conversation, the question is there leadership there which is going to take people and get them to really believe in this thing going forward?
I mean, to be fair to them, they are focusing on the 3+7 years. You've probably heard that. So the 3 years are really the must-dos, which are pretty similar to what was said in the 2000s with the NHS plan, with the extra bit of hospital-acquired infections. If you remember, that was another big must-do. Yeah. So I think that's the main thing that they have to do now to show at least some progress before the next election, because time is short, as we know.
Very wise words. Unfortunately, I find myself always saying this on podcasts. We are up against the buffers of time. And it's been so interesting. And I just wish we could do a 3-hour podcast, but unfortunately we can't. But Jennifer, fantastic to talk to you. And thank you so much. Thank you.
Lovely to see you. Good luck with everything.
Thank you very much, Jennifer. As ever, I always agree with a lot of what Jennifer said. The one thing we didn't touch on, which I wish we had, is the use of market mechanisms, which she and I certainly played with, if that's the right word, back in the 2000s. And there was a bit of market testing, and there seems to be a sort of interest in that now. So they're not playing this big, but that was one thing we didn't touch on. But I thought she was very clear on the funding question. I thought she was really honest about whether technology can actually deliver. And then there's the whole question of how do you motivate and move a staff group? Wasn't that interesting about the degree of disillusion which she detects among her profession, the medical profession? Because without the docs, dare I say, I don't think you achieve very much.
No, I absolutely agree. And isn't it interesting, Neil, that in all of this series of podcasts that we've done, everybody, and these some of the most elegant thinkers and some of the most high-powered people, they've all pretty much said the same thing. Arriving and saying the thing was busted was a bad move. The 10-year plan is too complicated. There isn't any money. The staff are all hacked off. We've got to find a vision, sell it, and slim down the 30-odd things in the 10-year plan to 3 things we can deliver. They've all said the same thing. The only people who aren't saying it are the politicians. Why is she and everybody else saying it, but the politicians aren't? Are they bonkers, or do they know something we don't know?
I do think that sitting in a political seat is different. You have different pressures. And I think it does encourage hyperbole. It does encourage you to say everything before me was terrible and now I'm in charge, everything will be all right. That was a problem way back in 97 when Frank Dobson came in and looked around the table and said, OK, what's this about a winter crisis? And they said, well, we're going to face a winter crisis, Secretary of State. And he said, no, we're not. Because we're in charge now and we're nice people and they were horrid people and they all giggled. I mean, they didn't do it in front of him, but they thought, welcome to reality of power. You know, we are, I think, right critical of what's happened, particularly around funding. First of all, the reforms of the 2012s, I think everybody agrees, including Tory ministers, were a disaster. And I'm not an economist, whether there was no alternative. But the reality is we have deprived this system not just of revenue, but we've deprived it of capital to a point where it is going to be really difficult over the next few years. If you're working on 2.8%, even if they had big sums they were going to put in capital, it would take a lot of time to rectify the landscape that we've got.
Absolutely. Capital was earmarked for 1%. And then there's the 40 hospital program, or 30 or 25 or 10 or whatever it is this week. Yeah, somebody needs to really just say, okay, folks, right, stop, take a breath. This is what we're going to do. 3 things. Let's get on with it. See you on the other side of the 3 things. Leave it to you. Get on with it. And, it's just so counter to how organizations work, how the dynamics of organizations work. It's contrary to everything we know to be right. I know. It's bonkers. That's my word of the week. Bonkers.
And on that note, on that bombshell, I think we should leave it. Thanks very much indeed again, Roy, and look forward to hopefully some of you joining us for our next podcast.
Bye-bye. Thanks for listening.